we're going to talk about paracetamol, which is acetaminophen in other parts of the world. It's a very common drug, and probably some of you have taken it this morning. Anybody who had paracetamol? You see? Did you have any overdose? No, because you're here. So I have no conflicts of interest to disclose. So from the 50s, since the 50s, paracetamol has been in use. It's the most widely used drug, probably, especially in Tanzania. And the reason being, it's available over the counter. You don't need a prescription for it. And we use it for several reasons. You have a fever, you take it. You experience some pain, you take it without even considering its negative effects. So before we move any further, before I talk about the role of high dose NAC and fomepizole, I thought it's important that I take you through some basic pharmacotoxicology. For those who went to med school, pharmacology, how many people like it? It has never been easy, but I'll simplify it this morning. Those who go through Muhimbili University know what pharmacology can do to you. You see, Mabula is laughing. So, primarily, the metabolism of paracetamol, acetaminophen is very new to me too, so I use paracetamol. The metabolism of paracetamol is through the liver. Okay, and there are mainly two pathways, the glucuronidation and sulfation pathway. And the addition one is through the cytochrome P450, 2E1 pathway, which takes less than 5% of the paracetamol. So in overdose, what happens is the two main pathways are overwhelmed or saturated. And there's a product which is N-acetyl-P-benzoquinone or NAPK that is produced, which is the source of the toxicity that we'll be talking about. So NAPK is a toxic metabolite that is safely reduced by glutathione within the liver to non-toxic mecapturic acid or mecaptate and cysteine compounds, which are then excreted in urine or through the renal system, the kidneys. When you have an overdose, these stores are the stores of glutathione, which are reducing factors or substances, are depleted. And once the levels reach below 30% of the normal, the NAPK, which is a toxic metabolite, starts to do its harmful effects. It binds to the hepatic macromolecules. That results in irreversible hepatic necrosis. Then we start talking about liver failure and dysfunction. So here is a diagrammatic representation. You have the two major pathways. Then you have the cytochrome P452E pathway that results into NAPK, which is a toxic metabolite. And later we'll see that you can use NAC, which is N-acetylcysteine, as an antidote to reverse the situation. So there are many ways that people can get poisoned. And the commonest, they're almost 50-50, but most of the time when you have people that have overdosed at the emergency department or at the hospital, it's because they took it intentionally, or maybe their kids. Intentional ingestion of paracetamol is one of the causes that people can get overdosed. People who are suicidal, they attempt suicide, take many pills, and unfortunately they can take multiple types of drugs. So you are in trouble. The second is an intentional poisoning. As I said, this is a commonly used drug, so unintentionally one can get overdosed. In people with chronic pain who take acetaminophen along with combinations, that increases the chances of toxicity and overdose. The commonest is acetaminophen and oxycodone. Then there is a syndrome of alcohol paracetamol, where people take paracetamol with alcohol. I don't know for what reason, but they do. and you end up in toxicity and overdoses. So we talk of paracetamol toxicity when the doses, the ingested doses, are above 10 grams or 200 milligrams per kg. Okay? And when you have people that have ingested beyond 30 grams, these are classified as massive ingestions or massive toxicities. And they require more aggressive therapies. And we'll see what we'll do. So when you have an immediate release paracetamol tablet, it usually takes 2 to 4 hours to peak. That is to show in its maximum levels. How do you know that they have been overdosed? You take serum acetaminophen concentrations. That's the basis. And it's the basis for treatment as well. So a diagnostic serum concentration is helpful even in absence of clinical symptoms, because clinical symptoms sometimes delay to show when you have delayed release symptoms. Then you are to use the nomogram, the famous Rumack-Matthew nomogram, which essentially predicts the potential toxicity beginning at the 4th hour after ingestion up to 24 hours after ingestion. Okay, so you plot it. It's a plot of the concentration of acetaminophen against time. Okay, that gives you the prediction. So it measures a 4-hour serum. You measure a 4-hour serum paracetamol concentration. Then you assess the potential risk for hepatotoxicity using this nomogram. If you can see, there is a Rumack line, one Rumack line that goes between maybe 300-ish. Okay? So if you have levels above the line, that is a probable hepatotoxicity, and levels below, when you're plotting, that is probably no toxicity. Then, when you have serum levels that fall in the toxic range, according to the Rumack-Matthew nomogram, after a single acute ingestion within 24 hours, you can think of giving N-acetylcysteine as an antidote. Okay? Another indication would be when you take liver enzymes and you have elevated liver transaminases that are thought to be caused by acetaminophen overdose. That's another indication to start N-acetylcysteine. Okay? So what is its role? The NAC has 4 possible modes of action. The first one is it increases glutathione availability. The second is it binds the NAP, which is a toxic metabolite. The third is it provides inorganic sulfate. You remember the other pathway of metabolism. The last is it reduces the toxic metabolite back to the original paracetamol. Okay? And it said that N-acetylcysteine is nearly 100% hepatoprotective when it's given within 8 hours after acute paracetamol ingestion. So it is recommended in patients with either possible or probable risk of hepatotoxicity. According to the Rumack-Matthew nomogram, you give it ideally within 8 to 10 hours post-ingestion. Now, to our talk. If you can look at the title of this talk, it's supposed to be the role of high-dose NAC and fomepizole. I took you through these previous slides so that we can have a baseline understanding. Okay? So where does this high-dose NAC come in? Currently, higher than standard FDA recommended. People from America, you there? Good. So higher than standard FDA recommended doses of intravenous N-acetylcysteine are recommended for some patients with massive paracetamol ingestions. So when you have that, you should consider that. Where does that come from? There have been reports of unexpected poor patients' outcomes, persisted poor outcomes, suggesting that maybe the ideal pharmacokinetic model used to come up with a Rumack-Matthew nomogram and the dosing of NAC has limitations. Okay? So there are also patients who have developed signs of hepatotoxicity despite a well-documented early presentation and prompt administration of N-acetylcysteine. So people came up with modifications, and the modifications were two. One is that included the modification of the Rumack-Matthew nomogram, and the second is the dosing of NAC in acute paracetamol toxicity. So here is the modified Rumack-Matthew. If you remember, the previous one had one line, supposedly the standard NAC dosing line. Now you have a no NAC line and a high dose NAC line above there. So when you're plotting your concentrations against time, you are to use the one in red. Okay? So in terms of the dosing, the green one is the standard dosing. You were to start with a loading dose of 150 milligrams per kg, then continue with the 50 and 100 kilograms per kg in 4th and 16th in 16 hours. Now the higher NAC dosing requires you to start with the same loading dose, which is 150 milligrams per kg, but the maintenance dose changes to 400 milligrams per kg over 24 hours. That is 20 milligrams per kg per hour. Can you follow? Great. There is also a classification based on types and characteristics and treatment approaches. So you have three scenarios where one has ingested less than 25 grams of acetaminophen. Then you have a massive one when they have massively ingested way more than 25 grams, and the variable ingestions, which present in different shapes and signs. I should emphasize that there is a role of activated charcoal based on time of presentation. I'll concentrate on the higher NAC dosing now. Okay. So when do you give it, and in what doses? So a higher dose of NAC is recommended for any case with paracetamol levels beyond or above 300 micrograms per mil. That is the risk line when you plot it. Okay? For cases where Rumack-Matthew nomogram cannot be used, or if liver dysfunction is already present, a level of 150 micrograms per mil is regarded as warranting high dose NAC. So you give it when you are in that situation. Then you continue. There's a continuous 24-hour infusion, which is begun promptly after the 150 milligrams per kilogram loading dose, and is given at a rate of 20 milligrams per kg per hour. That's high dose NAC. Okay? Then there is fomepizole. Fomepizole is originally used for toxic alcohols, but it has shown that it has a role in massive paracetamol toxicity. There are two ways that fomepizole works that can help in hepatotoxicity in paracetamol overdose. The first one, which is the primary, involves the inhibition of cytochrome P450 2E1. Okay? So when it inhibits this pathway, it prevents the conversion of paracetamol to the notorious NAC. Okay? The second one is through inhibition of the junk enzyme. And through inhibition of that, it reduces or it inhibits the NAP-induced activation of the junk enzyme. The junk enzyme ends up producing oxidative metabolites, reactive oxidant species, which are harmful to the liver. So what is its role in acetaminophen poisoning management? Fomepizole is recommended in massive paracetamol ingestion. And when we talk of massive, it's in the ranges of 500 to 600 milligrams per kg. Or in cases where 4-hour equivalent acetaminophen concentration is over 500 micrograms. Okay? So in cases of massive acetaminophen toxicity, you can use it in combination because it has been shown to decrease hepatotoxicity and mortality. But there's a caution to that because most of the evidence has come from case reports and animal models. This is where you turn into a proper emergency physician. I have something and I'm in a 50-50 situation. Do I give or not? Maybe evidence is not so strong, but it has shown benefit. So until there's more concrete evidence surrounding fomepizole use in paracetamol toxicity, its role should be reserved for massive paracetamol ingestions. So you're not to give it liberally. Okay, that is to say when you're in a do or die or not doing and dying situation, you can use it. So how do we dose it? When used in paracetamol poisoning, fomepizole is dosed in the same fashion or same way as used in toxic alcohols. You'll give 15 milligrams per kg loading dose, then repeat at 10 milligrams per kg every 12 hours for 48 hours. If it's still administered after 48 hours, it can induce its own metabolism. So you may need to increase the dose from 15 milligrams per kg every 12 hours. How is that? Is that new information? Isn't it? So, in conclusion, in massive paracetamol toxicity, the use of both high-dose NAC and fomepizole can be beneficial, but just in massive. Asante-san.
Thank you so much, Dr. Alphonse Simbila. So as we're just going to finish all the 3 morning presentation and then take questions or comments after that. Is that okay with everybody? Great.
So, good morning, everybody. Our next presenter is Dr. Gimbo Huya. So Dr. Gimbo is an emergency physician at Muhimbili National Hospital as well as a faculty member of Muhimbili University of Health and Allied Sciences. Dr. Gimbo also is an alumni member of Global Health Leadership Fellowship with Afya Bora Consultant, funded by PEPFAR and Harvard Medical School Global Health Clinical Research Program, CCRT. Also a certified member, trainer of WHO, Basic Emergency Care Course, and currently serves as a project lead in the NIHR-funded multi-mobility research project for the Tanzania MOAS team. So I'd love to welcome Dr. Gimbo to present. Thank you.
Thank you. Hi, I'm Gimbo. I'm Alphonse's classmate. Yeah, so I'm going to, how many of you know what nootropics are? Can I get a hand raise? 1. How many of you don't know what nootropics are? Great. Thank you. So that was me 1 month ago. And I'm just going to say this little story because it just piles up. This is me and Mabula around like October. We are talking and I'm like, oh, Mabula, like global health, need to talk about global health. Great, Gimbo. Also, there is this new thing, nootropics. I want you to present it. And I'm like, sure, I will. Like knowing in my head, like this is probably new ionotropics or it's an, I don't know, tropical disease, something, an emergency. fast forward 1 month ago, I'm like, okay, let me search what is going on in our country or what is new with nootropics. Guess what? I find out that nootropics are actually smart drugs. They are literally cognitive enhancers. So that is what nootropics are. So they are this new bunch of drugs that are either synthesized or there may be some sort of new plants or things that we have in our environment that either make us smart or enhance our cognition. So for a person who thought these are new types of inotropes to this was really interesting that I had to go through literature in the past 1 month or something. So guys, let's all get to know nootropics in hopefully 15 to 20 minutes. So yeah, as I said, nootropics are smart drugs. I found out there are actually 3 types. There are the ones that can be prescribed by a physician. There are the ones that are supplements that we use every day. And then there are ones that are just synthetic compounds. So like prescription are like Adderall. It's used for ADHD, we know, but apparently it can also be a nootropic. So mechanism of action, they do not work in the brain, make you smart by maybe releasing some sort of neurotransmitter, no. But they do have a mechanism of action that at the end of the day increase blood flow to the brain, increase glucose to the brain. A lot of them have some sort of an antioxidant effect, and a lot of them have some sort of brain protection effect. They are indicated, so for those that are prescribed, literature says that if you prescribe it as a physician or as a prescriber in whatever setting you're working, you can prescribe it in acute or subacute conditions where you want to improve memory, consciousness, or learning disorders. You can prescribe it in very mild brain damages that manifest with memories issues or retardation issues. You can prescribe it in chronic brain conditions like chronic stroke patients. I saw a paper in Spain where they tried this. There was improvement in patients who presented with chronic stroke conditions, and also in patients who have rather attention or memory disorders. If you notice, I said like most of the things that you can prescribe, patients have to be sick. So newer studies are trying to see, can you use it in healthy individual like me and you, with a very good assumption that a good percent of us are healthy. We don't have a stroke or something like that. So studies try to look, can you use it in to make us smart who are healthy? And one of the randomized trial, a blinded trial that was done in Spain, it was a placebo-controlled crossover trial, actually proved that in health individuals, this can be used to improve or make you smart otherwise. Otherwise, there are not a lot of studies that are done in sub-Saharan low to middle income country, and I guess it makes sense. We have a lot of problem of public health importance than to see if a drug can make us smart. But then I don't know, maybe this is also a room for us having to investigate these things, and as I come and cover some of the nootropics that we have in our system, you'll come and find things that are available in our settings. So treatments, as I said, when you prescribe it, treatments is usually well related, and effects start 2 to 3 weeks in, so it's a long-term effect, and some effect can even take six months to even a year. They're contraindicated in people who are who have hypersensitivity issues, in pregnant women, or in anybody who is lactating. Science says there are 4 main subgroups. There are classic nootropic compounds. There are substances that usually increase brain metabolism. There are cholinergics, and then there are plants, basically plants that we see every day as extractions. So I'll start with, I'm just going to take you through some of the nootropics. There are 100 of them, but I chose things that I felt we could all relate to, and this was one of the most interesting one, coffee. This was interesting to me. So apparently we all know coffee usually increases your concentration, so it's one of the really good nootropics. So everybody, let's try taking coffee so that we can get smart. But anyway, so coffee, we all know increases your concentration, you're able to stay awake, you're able to focus. One of the nootropic effects that studies have shown is it blocks adenosine. If we remember Microbiology, if you remember biochem, adenosine usually makes you lazy. It's one of those that makes you lazy, that makes you drowsiness. So it blocks a lot of adenosine. As a result, you're more active. And another thing is it improves brain entropy, which basically means your brain is able to process more things. So the higher the entropy, the more your brain can process more things. So it blocks that and increases the entropy. So that's how it is. And then studies that were done in high-income countries, there are 2-3 studies that I looked at that showed that it reduces cognitive decline as you get old. And most of the studies were actually done in the US. Again, nothing was done in our settings, but yeah. The second one, again, as a drug, it's called resveratrol, but naturally you can find it in any purple red sort of fruit. So your grapes, your blackberry, your blueberries, your strawberries, and my favorite, wine or dark chocolate. So all of these can have this type, and its effect is by preventing deterioration of your hippocampus. Again, taking us back to our anatomy, our sciences, the hippocampus is in charge of memory, so it improves your memory. So take all the grapes you guys can today, okay? And then the third one, when I was looking at these objects, or rather at these drugs and supplements, is fish oil. So fish oil, naturally, it has a lot of omega-3, highly concentrated, which is good for your brain. It has an anti-inflammatory effect that protects the brain against any damages and any aging. But what you should know is, if you do not want to take fish oil, if you take 2 portions of oily fish per week, you'd have enough amount of omega-3 to have the same sort of effect. So either one. The other one that was interesting was ginkgo biloba. I want to give a precaution when it comes to coffee. There was obviously, I think this is something we know. You have to be very careful with the amount of coffee you take because of cardiac effect and all that. Looking at this also reminded me, because ginkgo biloba is very common, and I've seen in our settings, in private clinics, stroke patients are prescribed this, especially stroke patients with memory issues. I personally have witnessed this. So this is it's a leaf. The effective part of it is its seed and its leaf. It increases blood flow to the brain. There are pills that are available. You can see one of the pills is out there. So there are pills that are available, and apart from just improving memory, that is recoil and speed, it has been shown that taking these pills can also help with anxiety, it can help with depression, and it can also help with concentration problems. And then I'll move to the other one. This is one before last. As I told you, my presentation is very short. I had to pick the things that I liked and I could relate to. Is ginseng. Ginseng roots is what is used. There's a picture of roots there. So the effective thing is root. There is what they call white ginseng, and then there is what they call red ginseng. White ginseng is usually they peel off the roots and then they dry them. You get this sort of white powder, while red is like they steam the roots and then they dry them, so you get the red ginseng. Just like the previous things, the previous ones that I've talked to, they're also pills formulation of it. So if you can get the roots, good. If you can't, then you can get pills. Again, this, you should be very cautious with this. It's very commonly used, especially there's even a tea version of it. But you should be cautious if in people who are having like bleeding issues, because one of the side effects is it can cause bleeding. It has anticoagulative effects. And then the last one, Holy Land is linking. Okay, the last one, that's fine. The last one is lecithin. Lecithin normally is found in nuts, it's found in bread, it's found in egg yolk. It's one of those cholinergic types, and just like the previous one, it increases oxygenation to the brain by increasing blood flow to the brain and increasing supply to the brain. It's also good with concentration. It's also good with memory. And I think those are just a bunch of them I wanted to cover. But one of the most important things I've seen, as I said, first of all, there is no data for low to middle income country to this, but there is a lot of supportive data for healthy individuals. There is a lot of data that supports sick individuals, either mild or moderate already cognitive or memory issues. Mild, only 1 or 2 data for healthy individuals, none in a low to middle income settings. They say effects usually take a long time. Most of these substances or most of these drugs that have a natural origin, so you can always try natural before you switch to pills. They have an ability to increase both intelligence and memory in university students, and some of the studies have proven this. They are available in the internet. As I said, there's some that can be prescribed, there's some that cannot be prescribed, there's some that you can just get in the market. So in summary, these are new groups of drugs that I learned last month, and some of you learned today. They are called smart drugs, they are called cognitive drugs. Some of these things are naturally available. No, it's fine. Some of these things are naturally available, such as coffee, such as grapes, such as fish oil, or eating fish, or cheese. Actually, there was beautiful pictures of cheese there that if my was projected, but there was cheese and milk, some of these things which are high, in this is because they have a high level of B6, B12. So yeah, I think that's a very short presentation of what nootropic is, and I'm glad that I got to learn with a lot of you that was your first time to learn this. This is it. As I said, my presentation will not be all 30 minutes. It's very short because I think if you're learning a new thing, let's take it in small doses. Great? Hi, I'm back. Yeah, so our next presenter was supposed to be Happiness, who is taking us through TBI, the ideal management, but Happiness couldn't make it, and Kelly, who is a neurosurgical fellow from Arizona and KCMC Moshi, will take us through that. You're welcome.
Good morning, everybody. I'm Dr. Carrie Vaughn. I'm a pediatric neurosurgeon by background, working with Dr. Rabiel Happiness now at KCMC from a hospital collaboration in Phoenix, Arizona from Barrow. And I'm going to be covering the same topic as her, essentially TBI and kind of global management. How do we manage it in the pre-hospital and acute settings, and what applies to emergency care staff? So I'll try to keep this a bird's eye view and relevant to what you see hopefully in your practices and in your settings. There's a whole range of what we do in terms of TBI management, and it's continuously evolving. So there's guidelines that come out and often get revised, and we try to take a summary of all the guidelines out there essentially to what makes sense and what we think the best data shows us in terms of TBI management. So I'll do a quick review of TBI just to make sure that we're all on the same page, because speaking a common language around traumatic brain injuries is incredibly important. It is a very heterogeneous word that people use to describe a lot of different conditions. So making sure that we're speaking a common language really serves as the basis of optimizing care for these patients. And then I'll go into a little bit of the management in pre-hospital and acute hospital settings. I won't go so much into long-term management beyond just mentioning what it's there for. So what is TBI? One definition that is long but attempts to encompass a lot of what traumatic brain injury is comes from Syed et al. In 2007. Essentially an insult to the brain that's not degenerative, that's not congenital, that comes from an external mechanical force of some sort that can have permanent or temporary impairments in multiple modalities that the brain controls. Again, whether that's cognitive, physical, psychosocial. So it's really anything that impairs the brain temporarily or permanent from an external force, again, that we can't attribute to something like genetics or degenerative conditions. And it's really a broad term that, again, people use in very different ways. So trying to summarize traumatic brain injury literature can be challenging because of these various definitions. So this serves, again, as a lengthy but hopefully kind of encompassing definition that allows us to speak a common language. And we'll use this term to define both clinical syndromes as well as diagnostic entities, for example, things that we can diagnose on imaging, structural injury to the brain. So when I say that, when I use the term traumatic brain injuries, I'll use it to mean anything from concussion syndromes, as we typically understand concussion, I'll cover a little bit of that later, to structural brain injury, again, that we can see on imaging, and we'll review a little bit of that. It's really important that beyond being able to define traumatic brain injuries in a way that we can all understand and agree on, we also know how to describe or communicate around patients with TBI in a common language, so with similar tools. That often includes, our standard clinical exam and history. That is obviously the basis of any patient care before the hospital, in the field, all the way up into the hospital and beyond to rehab, home, whatever setting the patient may go on to. The patient exam, we try to stick to clinical tools that allow us to summarize the patient's status, the patient's exam rapidly, and that people are familiar with, so that we can quickly communicate, this is my general impression of how this patient is doing right now, without having a lengthy narrative description. Sometimes that's helpful, but usually in trauma situations, time is of the essence, as we know, and we try to rapidly summarize the clinical status using some tools, and I'll cover a couple of our basic ones. Obviously, imaging is another common language. We're very comfortable speaking about images, trying to be able to relay that to other healthcare staff quickly and efficiently so that they have a meaningful understanding of images, even if they haven't seen the pictures themselves, is really, really important. We're lucky that we have technology now to be able to share those images rapidly. That's not always an option, though. So again, that communication piece is so, so critical for TBI patients, and I think a recurring theme of this conference around being able to share knowledge and information quickly and efficiently. This synthesis for us often, is kind of summarized down to the Glasgow Coma Scale. That's one of our common language tools, we'll say, for TBI patients. I think most of you are familiar with this. I won't go into the components, but it's really become a standard tool. Even though it's imperfect, we recognize it doesn't summarize the entirety of the patient's status. But if you're able to convey, the patient's Glasgow Coma Scale score to another healthcare team member, as well as, for example, their vitals, and maybe a brief neurological description beyond that of any focal injuries. By that I mean, for example, are they not moving half of their body? Are they not moving one of their limbs? And then do they have any other traumatic injuries? Those components will give you a surprising amount of information to be able to rapidly triage, especially if you're connecting with specialists, for example, on the neurosurgery team, and trying to help us decide, how quickly do we need to triage this patient? What do we need as far as diagnostic testing for this patient? This is an incredible tool. Again, although imperfect, it doesn't give you a complete picture, but it gives us enough of a general sense to be able to say, okay, this is where I think the patient is in terms of severity of injuries relative to traumatic brain injuries, and then here are the other, traumatic injuries to keep in mind in addition. So we know that TBI is a significant problem around the world, and one of the highest causes of mortality, especially in younger populations, pediatric and young adults. Globally, we know that there are efforts to try to standardize capturing data around TBI prevalence. There's a number of registries that are really making efforts to collect high quality data around TBI incidence and prevalence and mechanisms from a variety of different settings. Because although there's common themes as to how TBI occurs around the world, obviously there's going to be variations in those populations depending on the setting that you're living and working in. So, even though road traffic accidents are a very common cause of traumatic brain injury all around the world, the severity of that depends or changes a lot across settings depending on the type of vehicles that are most common on the road, the type of road safety rules that exist and are or are not followed, as the case may be, the type of drivers that are behind the wheel and whether they're more likely to take risks or, for example, drink alcohol while driving. So all of those nuances are really important to capture so that we can understand who is getting TBI, how are they being managed currently, and how can we improve our TBI management globally, again, in the field, in the acute setting, in the emergency room, and beyond, inpatient, onwards to getting them home, hopefully. So again, there's a lot of international registries working on capturing that data. There are some groups that have tried to summarize the global incidence of traumatic brain injury, but again, because of that really variable definition of traumatic brain injuries, it's actually quite hard to turn it into a meta-analysis, a robust meta-analysis. So sorting to try to make sure papers are using a similar definition of traumatic brain injury is difficult. What we've been able to summarize or to understand is that there's usually about 69 million people every year who have some sort of traumatic brain injury. Again, and that can be the entire range from a very mild, temporary, transient disturbance in consciousness all the way to a fatal traumatic brain injury. Road traffic accidents are the most common mechanism for TBI globally, and this is highest across the African region as well as in Southeast Asia. I don't think that's a surprise to anybody in this audience. That's a lot of what we see, and unfortunately, this happens to especially younger people who are more likely to be on the road. And it's lowest, surprisingly, in North America, where there's more variety of traumatic mechanisms, partly because of the age distribution. As people get older, they're more likely to have TBI from relatively minor mechanisms or low velocity mechanisms, such as falls from standing or falls down steps. And the incidence of road traffic accidents, we can estimate at around 1 to 1.5% of the population for those regions where there was enough data to summarize it in Southeast Asia and Europe. I suspect if we're able to get enough data to look at that in Tanzania and in the African region, it's going to be higher. And very, very importantly, low and middle income countries experience 3 times more cases of TBI proportionally than high income countries. And this is just based on limited data. So imagine once we're actually able to collect high quality data on traumatic brain injuries in a number of different settings, just how much more we can understand and advocate for better care before these patients reach the hospital, in the emergency room, in the ICU, in the OR, wherever they need to go. This is really going to be crucial, I think, for us to advocate towards governments to address these major trauma mechanisms that we see on the TBI side. So again, this is a graphic representation of the overall incidence of TBI. And although in the data summary, they found that the overall incidence of TBI is lowest in Africa with 800 cases per 100,000 people, I think a lot of that is because we just don't have the data. you can hear a recurring theme when I'm talking of we need more data, obviously. We know it's a problem. We see it every day in our practices here. Even in a somewhat smaller town like where I am in Moshi, we see so many of these referral cases from all the health centers nearby and just from within our own town. So this doesn't, these data don't reflect the whole story. We have a long road to go on improving patient care, again, starting by just understanding and putting numbers to what we're dealing with. Here in Tanzania, we don't have national incidence data, at least not that I've been able to find. There are a couple of TBI registries, one at KCMC and one in Dar es Salaam at the National Hospital in Moi. And the patterns that we see are that the patients affected by TBI are predominantly male, no surprise there, but around 80% of TBI patients are male compared to female. And there's a high mortality and morbidity rate associated. About 12% of patients have a risk of mortality if they're diagnosed with a TBI. Most of these, about 2/3 of TBI patients, are from road traffic accidents, which is a little bit higher than what was estimated globally, but in line with those numbers. And again, the age that these patients tend to represent is fairly young. The median age is around 30 years old. So especially with the high morbidity and mortality, you put that together, it's a young, most often male population getting traumatic brain injuries with a high risk of disability or death from this. It is wasting an entire generation's brains, in my point of view. This is why the urgency, I feel a huge urgency in getting better data and treating these patients, because there is an entire generation that is losing their ability to function, to be able to support their families, and potentially dying from something that, with a lot of effort, governmental support, we could fix. Road traffic accidents, again, are 2/3 of this population. So if we start to address that, maybe we can start to tackle prevention of TBI, which I'd rather be talking about prevention of TBI than the part that I deal with, which is attempting to salvage TBI on the surgical end. But we're not going to be preventing all of TBI up front. So why do we treat it? Well, obviously on the first end is resuscitation, making sure that we keep the patient well evaluated and resuscitated or as quickly as possible. So rapid, safe, and monitored triage and transport is critical. Obviously, there are big challenges to that in different settings where there might not be EMS or emergency medical services to safely transport a patient. So there are delays to referral, there are limited capabilities of triage, a lot of different challenges that we face in different settings around the world that we have to tailor our solutions to. On the other end, why do we treat it, in the hospital and beyond? We can't undo the initial traumatic brain injury, but what we can try to do is minimize the damage from secondary brain injury. And these are injuries that happen over the first few days after a patient has had their accident, their traumatic event. And these secondary injuries to the brain happen through a few different mechanisms. Things like an inflammatory cascade response in the brain to trauma, cell death and cytotoxic edema, similar to a stroke. Brain is dying, and as much as we can prevent additional brain dying, hopefully that improves outcomes for these patients a little bit. If they happen to have blood in their brain somewhere, in or around their brain, if that hematoma grows, that can cause additional damage, of course, from a mechanical standpoint. As that blood breaks down over time, those blood breakdown products are toxic to the brain and can cause additional damage. And then scarring from traumatic brain injuries, even on a micro scale, can cause a lot of complications for these patients long term. That scarring in the brain is at high risk of leading to seizures for the patient over the course of their lifetime. That's part of the counseling that we do for any TBI patient, especially if we know that they have had brain injuries that we can see on CT. But even for patients who've had brain injuries without any changes on CT, there's still a small chance of them developing seizures over the course of their lifetime. It's very small, but it's still there. So especially if we then do see injuries on CT, they're more like, they have a higher chance of developing seizures over the course of their life. So it's really long-term risk of disability. Even that's part of why prevention of secondary injury is so critical, and why time is brain, really. It's true for stroke, it's true for traumatic brain injuries, it's true for cancer. So any neurological disease, you know, we tend to think of time as brain. As much as we can get to these patients early and manage them, hopefully the better the outcomes. So now what about in the field? That is obviously going to depend on what resources you have. You know, if you have somebody with healthcare experience that happens to be there and can assess the patient, great. I know that emergency medical services are not available widely, for example, in Tanzania, and are incredibly costly. So oftentimes these patients are brought in, again, with delays, maybe by family or friends or by public transport. They might be seen at other health facilities that are not comfortable with neurological patients, with TBI patients first. So we have additional challenges where we might be already behind in terms of managing these patients. That doesn't mean that taking care of them is futile. Even if they come a few days after an injury, we can still try to prevent those late secondary injuries, the late inflammation after TBI, to help the patient as much as possible. We can't reverse what happened before the patient came to us, but again, we can try to minimize the damage from when they come to us onwards. So in the field, if there isn't, you know, any healthcare personnel or expertise available, the best thing that we can do is, as far as public education, is just instill a sense of urgency in people and say, hey, if you think somebody has had some injury to their head or maybe multiple injuries around their body, bring them to a healthcare setting as quickly as is feasible. Again, it's going to depend on resources. You know, if they don't have access to a Boda nearby, it might take a while to find one or to pay for transport. But that sense of urgency is really critical, and one of the main messages that we can pass on to the public as healthcare staff is say, hey, if something happens, try to bring them to healthcare settings as quickly as possible. You know, just don't pass go, you know, just bring them straight to whatever healthcare facility is nearby, and hopefully they can then direct the patient. It might, depending on the logistics, transferring to a trauma center isn't always feasible, but that's part of our education mission, is public education, as I mentioned, instilling that sense of urgency. And then on the healthcare side, as emergency staff, you have a huge opportunity to train healthcare staff in smaller health facilities nearby in kind of your referral regions on what does it mean to have a TBI? What should you do as healthcare staff? You know, and they can learn a very quick triage and then be able to hopefully pick up the phone and call you to let you know, we have this patient at our facility, you know, what do you think we can do here? How can we transfer them to you safely, or where do you think they should go? So especially if there are signs of traumatic brain injury in the field, you know, obviously if somebody's able to relay that to you as emergency staff or to the local facility, that can help expedite, okay, preparation of materials for the patients. You know, speaking with pharmacists and other team members to have all the resources available possible at whatever setting the patient's going to be directed to. And again, part of this is also advocating over time. If we don't have emergency services, how can we help to grow that over the long term? This is obviously not going to get fixed tomorrow, but how can we use this to help advocate for why emergency services in the field and, you know, pre-hospital transport is so critical to taking care of these patients. And TBI is just one piece of the equation. You know, trauma patients in general are obviously a bigger portion of this, and you can advocate that for other diseases as well, other emergencies, strokes, you know, myocardial infarctions. But all of these pieces together can help us raise our voices, you know, towards the government and say, hey, this is why we need more support for pre-hospital patient triage, monitoring, et cetera. So in terms of clinical assessment, that can start, again, in the field if you have somebody capable, or on the way, or if once they reach the emergency setting, looking for symptoms. And I wanted to mention specifically concussion because that word can be used very variably. And there's a whole range of symptoms. So anything from very vague symptoms of I feel a little dizzy to nausea, vomiting, all of these can range and be part of concussion. And that's important because concussion is, again, another term like TBI that's used very variably. Some people use it to mean purely a clinical syndrome with some of those vague neurological symptoms, and they might not imply anything about whether there's changes on imaging, if there's any damage on a CT scan to the brain. So be mindful that somebody can use the term concussion very differently and mean, this is how the patient is clinically. I'm not talking at all about the CT scan. Some people will use the term to say, hey, this patient has, neurological symptoms, but they don't have anything on CT scan. So I would encourage you to always clarify. If somebody says concussion, ask them, what do you mean? Do you mean they just have clinical symptoms and their CT scan has no injury? Or does that not include the CT scan, for example, if that's available? So moving on to more acute management, transitioning away from the field, the treatment timeline is, again, critical here. I keep mentioning the idea of time is brain. This is where an experienced team that's comfortable managing these patients and has, protocols, guidelines, whatever it may be that can help them to expedite care is really important. And this, it doesn't take a lot to form this, even if you don't have a lot of resources. It revolves around education and practice, having a team that's comfortable with each other and that practices mock patients. For example, how to quickly triage a TBI patient. These little scenarios can build confidence and the ability to communicate within an emergency setting team that can help speed up care for patients, again, with the ultimate goal of hopefully improving outcomes and triage to the right disposition after, whether that's inpatient, outpatient, ICU, what have you. So again, a team effort is really critical for these patients. One person can't do it alone. Sometimes you don't have any other options, but practice and communication are essential skills, speaking a common language around these patients. Again, all of these recurring themes have been shown to make a big difference in outcomes for traumatic brain injury patients and trauma systems in general, especially in emergency settings. So for these patients, if they come early enough to a healthcare setting, these first hours are really, really critical for us. We usually think of the first 48 to 72 hours as critical in us being able to prevent as much secondary brain injury as possible, as well as early monitoring for us to determine, are they deteriorating? What do we think their long-term outcomes are going to be? And we're not always incredibly precise about how we can predict long-term outcomes. We usually have a general sense of, we think this patient will do well, we think this patient might have these disabilities, have paralysis on one side, neurocognitive deficits, but it's not entirely precise. So we have been proven wrong before, and I'm sure we will continue to be proven wrong. So we take predictions with a grain of salt, but we want to prepare families when we're speaking with them early about, this could be very tricky for your family members over the next few days. We need to monitor them closely and take care of them, in a hospital setting if we think the injury is severe. So in the emergency department, again, I spoke a little bit about teams, et cetera, but the actual assessment component, we rely on the basics of trauma care that you're all familiar with, again, in ED settings. Your standard A, B, C, D, E's, that should always be your first step. And we get a lot of neurological information out of that, as well as the primary and secondary surveys. So on the neurological side, specifically for those, we'll look at the vitals from your primary and secondary survey. The neurological exam that's a part of those surveys is really important information for us on the neurosurgery end, on the specialized end, to understand how the patient is doing early when they first get to a monitored setting typically. Other forms of neuromonitoring that's really important to us early is the neurological exam in a little bit more detail. You've given us the vitals and the Glasgow Coma Scale, for example. Then you can give us a little bit more detail potentially about, okay, I see that their right arm is not moving. I don't know yet if that's from a neurological injury, an orthopedic injury, what have you, But those little pieces of information early on are really critical to pass on to the relevant teams. Imaging, for us, is a form of neuromonitoring. Usually, hopefully, if needed, they're able to get one CT scan as a first step, and then see if we need to repeat it. That's obviously limited a lot of the times by resources and constraints and financial access to imaging, but if available, sometimes it's clinically necessary. And then consulting other teams, like the neurosurgery team, as is relevant. All of the goals of treatment in terms of numbers, the ones that you see up here for different parameters, are all essentially optimizing vitals. And some of them, are not going to be feasible, like monitoring intracranial pressure when indicated, and we'll cover that after, is not always possible. And then we rely on going back to the basics, the neurological exam, and changes over time. But at the very basic level, vital monitoring, blood pressure, O2 sat, et cetera, are going to be critical pieces of information, because those can give us clues as to how the patient is doing, whether there's signs of improvement or whether there might be impending deterioration. Again, imaging is another form of neuromonitoring that's really important to us. I won't belabor different types of TBI, just knowing how to talk about what you see on CT scan, again, in a common language, is really important. If you're not sure if there's anything, if you have access to a radiologist, speaking with the radiologist and reviewing images with them doesn't take a long time. It can happen over the phone or going to the radiology room, but can provide a lot of information and that you're able to pass on to other teams involved in the patient's care. ICP monitoring, I mentioned again, it's not always feasible, but just to talk a little bit about it so that you understand what some of the measures that we use to treat ICP are for, and when it is available, what numbers we're kind of targeting. So it's meant to measure intracranial pressure, and that can be done a couple different ways, either with an external ventricular drain, which is the diagram you see here, with a small catheter inserted into the ventricles of the brain, and that can be done almost at any age for a patient of any age, and that measures the pressures in the ventricles. There are also small probes that we can use to measure pressure in the parenchyma of the brain itself, in the brain matter itself. Typically, we'll tend to think about external ventricular drains first, because those also allow us to drain CSF to the outside, to this collection system you see on the right of the diagram, thus allowing us to relieve a little bit of pressure at the same time. They're prone to blockage and malfunction and require nurses that are comfortable taking care of them. They're often, patients that we have in the ICU, for example, but we can put these in emergency settings very quickly, in 20, 30 minutes if we have to, under time pressure, and start monitoring right away. So it is something that can be done rapidly, and that we're hoping to start to bring into emergency setting cultures around Tanzania to start to get a little bit more information around these TBI patients. A rough proxy of intracranial pressure is your neurological exam, but again, it's by no means perfect, because there can be a lot of different factors affecting intracranial pressure and the neurological exam. So changes in the patient's neurological status might not necessarily mean that it's from a change in intracranial pressure. That's why ICP monitoring doesn't replace the exam, but it can give a little bit more information in addition to the exam. We typically target an ICP of 20. Sometimes we'll tolerate up to 20 to 25 millimeters of mercury. Can be measured in a couple different scales, either mercury or centimeters of water. So again, making sure that you're speaking a common language if you do run across these. But that's about the target where we think is normal. And there's some debate around that. Again, going back to when I mentioned guidelines will change over time and recommendations. The 20 is not as hard and fast of a number as it used to be. But we tend to think that if ICP stays above 25 for a prolonged period of time, that tends to lead to worse outcomes from TBI. And there's different strategies that we can use to target that. This is what I'm going to focus on in terms of the acute management just for a few minutes. because this is a lot of what you can help to treat even early on in an emergency setting. There are some very, very basic measures that you can start with. If you think a patient is experiencing elevated intracranial pressure from their injury, especially if you have a CT scan to help give you a little bit more information, you can start with some very basic measures. Sitting the patient up, for example, 30 degrees or so for the head of bed, allows for improved venous drainage and can help decrease the intracranial pressure a little bit. So there's small measures like that, making sure the patient is comfortable and not in pain, so treating their pain adequately, especially if they have other injuries, if they're a polytrauma patient, that can help to reduce ICP a little bit and make them more comfortable. Close monitoring, repeat clinical exams, repeat imaging if possible, if necessary, are also important forms to help to try to predict, do we think this patient is going to deteriorate? Again, especially within the first 2-3 days after injury. And sometimes patients don't present within that window. Sometimes they present a week or 2 weeks after their injury. They might still need this type of monitoring, even if they're out of that very, very acute phase. If those measures don't help, then there's a whole other list of things that we can go down to help treat those patients. But again, same principles apply, is monitoring the patient, whether that's, again, just clinical exam, which is most of what we have available, or if you have extra monitoring, like intracranial pressure monitoring to help you, repeat imaging, and then along the lines of treating their pain, you can start to use more and various sedating agents, or even going towards paralysis if their airway is secured, to help to try to lower intracranial pressure. And these all come from the guidelines from the American College of Surgeons that provides a good summary, and that's maybe a little bit more accessible, for example, than some of the neurosurgical guidelines that tend to be more focused on our piece on the surgical management. Notice I haven't talked about surgery yet, apart from the intracranial pressure monitor at this point. Another part of this is starting to think about hyperosmolar therapy. That's really the other category of medications that you might have access to in emergency settings that can be really, really important for these patients. And there's typically little downside to giving it if you're not entirely sure how much of what you see in the patient's exam is from intracranial pressure elevation. So if you think there might be a chance that the patient's not doing well, has a low Glasgow Coma Scale score because of high ICP, again, there's usually little downside to giving hyperosmolar therapy, and that's either mannitol or hypertonic saline, or occasionally both alternating. I think most settings have easier access to hypertonic saline, at least for the few areas I've worked in across Africa and North America. But mannitol is another option. So those are medications that you might be able to start to administer even as you're continuing your assessment in more depth to help manage the patient early. And again, adequate sedation ranging from just very light analgesic management and sedation all the way down to paralysis if need be. Those can assist with bringing down intracranial pressure. If all of that fails, then the next steps are more aggressive medical management and consideration of surgery. More aggressive medical management is going to be, for example, complete neuromuscular paralysis on a continuous infusion, eventually maybe even a barbiturate coma. Those are not very common and are for really, really refractory intracranial pressure elevations. Typically, by the time we get to this decision making, the patient is in an ICU setting and likely no longer in an emergency setting, unless the ICU is full. But this level of decision should be made in conjunction with multiple teams, with the acute team, again, whether that's emergency or ICU physicians, and typically the neurosurgery team, because the other options at this late stage tend to be things like surgical decompression. Hemicraniectomy is what we typically think of. And that often our surgical management is tailored to removing the bone to allow brain expansion and relieving some of the space limitations on brain. And this often happens because of the massive edema following trauma over the next 2-3 days is typically where we see most of the edema happening. And that's usually our window for considering, do we need to do a decompression hemicraniectomy. Again, that involves removing a piece of bone temporarily for a few weeks to try to alleviate pressure and allow the patient to recover. The only caveat to surgery is if there is a space-occupying lesion, meaning if they have a hematoma, for example, like I showed earlier, if they have an epidural hematoma or a subdural hematoma, that might require surgery right away. So that's the one differential where we might consider surgery early, as opposed to trying all those different measures to control intracranial pressure first before thinking about decompression surgery. In terms of the decompression hemicraniectomies, there is a lot of back and forth and a lot of evolution of our guidelines around when that might be appropriate. So you will hear a lot of various opinions depending on the neurosurgeon you're speaking to as to when that's appropriate, you know, what part of the head, because we can modulate it to where the edema is or how the patient is appearing. So just know that the guidelines are not set in stone on the TBI side or on the surgical management of TBI side for us. There is going to be a lot of variation across surgeons. And if you're not sure, you know, just ask questions of your colleagues. Be like, take me through your thought process. You know, I don't understand why you're treating this patient that way and that patient that way. And there should be logic behind that. There's no single right answer that we know of. We try to practice as best we can by the guidelines, by the evidence we have, but always have that conversation with your colleagues to try to educate, you know, yourselves and be able to pass that on to your patients in caring for your patients and their families. So beyond that acute management, obviously, the couple themes I want you to take home from all of this are things that I've already mentioned earlier in the talk, meaning we need better data. I mentioned that there's a couple registries out there trying to gather better TBI data across pre-hospital and acute settings so that we understand really the nuances of these patients that we see across the world. It's as I said, it's absolutely a public health crisis. The amount of disability and death from traumatic brain injury, especially to young people, you know, young adults and to children. So this is something that we have to keep raising our voices about to whoever will listen, including the governments, so that we can enact change, so that we can get better road safety rules, so that we can get better pre-hospital services, so that we can improve care in the emergency room and rapid triage onto whatever the next most appropriate setting is. And to that effect, there are collaborations across the world, and we try to collaborate closely with our emergency colleagues to improve that care, because we know that tight communication and teamwork is critical to improving care for these patients. We've got ongoing work, you know, for example, at KCMC with our emergency colleagues locally as well as international partners to try to understand who are these patients that we see coming in with TBI, how can we better help them, how are they doing after their initial injury, how can we change that over the long run. And then education, I brought that message a few different times of highlighting education for ourselves as healthcare staff as well as for the community at large, and understanding why it's so urgent to take care of these patients for the individual patient on the field as well as beyond, just trying to reduce the burden of TBI eventually through prevention primarily. That's the ultimate goal. But secondarily, by treating the patients quickly, safely, you know, as much as we can to prevent secondary injury. So thank you for letting me come to present to you. It's always a pleasure collaborating with our emergency setting colleagues, and hopefully I was able to share some new information with you.
Thank you so much, Dr. Kerry. Next, for presentation, we have Dr. Kuzema Kanibai. Dr. Kuzema is an interventional cardiologist at the National Jakaya Kikwete Cardiac Institute, JKCI. His expertise in all echocardiography modalities and cardiac catheterization procedures. These include coronary angiography, angiography and angioplasty, peripheral interventional device and peripheral device implantation. He mentors cardiology fellows, internal medicine residents, and undergraduate students that rotates in the cardiac unit. He is involved in conducting research that focuses on addressing the care of acute coronary syndrome from multiple perspectives and contributed to several publications in diagnosis and management of patients with ACS. In addition, he is one of the few interventional trained cardiologists in the nation, that is in Tanzania. He oversees the National Registry of Cardiovascular Disease, that's NCDR, which is affiliated with the American College of Cardiology. He serves as a member of ethics in the JKCI, that is Jakaya Kikwete Cardiac Institute. He is also an honorary lecturer with the Muhimbili University of Health and Allied Sciences.
Good morning, everyone. Thank you for a big introduction, but at the end of the day, we are all colleagues. So I would like to thank the SQL Foundation and Dr. Peter Mabula for inviting me here. And the topic I'm going to present, it starts from you guys. If you guys recognize these patients early, we can do early intervention. So it's as important for us, it's as important as for you. So I'll go through the presentation, and it's a mixed bag of presentation because I put a clinical case which came from Arusha to us. So it's a case how it was managed in Arusha and how it reached to us and how we did the intervention and how the time frame, which is the most important. Like the previous speaker told us that brain time is brain, we say time is muscle for us. So for us to save the muscle is the most important thing. So I'll update you also on the management, current management we just published last year in European Society of Cardiology 2023 on acute coronary syndrome. So I have no disclosures. So let's go in with some of the data which was from the, I think the fonts has changed itself. So cardiovascular disease is the most common cause of mortality and morbidity worldwide, and a substantial portion of burden is borne by the low and middle income countries, which will be a part of it. And ACS is often the first clinical syndrome manifestation in cardiovascular disease. And there was estimated that few million cases of ischemic heart disease in 57 European countries, member countries, were noted down last year. The cardiovascular disease remained as the most common cause of death within the S community and S member countries. This which we are talking about the European side. We don't have data on our continent at all, and that how much burden of cardiovascular disease we have. We have few data which was from small studies, but we don't have major data from the countries around Africa. And this is an area which is a gray zone. We are fighting there to get data from every country. And it's the most common cause of death in both males and female. It almost accounts equally in male and female. Males percentage is 44 versus female 38%. The growing burden of sub-Saharan ACS in sub-Saharan countries is attributed to limited access of the revascularization modalities and a delays in the referral because of the primary diagnosis of acute coronary syndrome. And this leads to that the first thing to get an ECG. And the recent study which we did, we run a very big WhatsApp group which is called a STEMI group, and we've got over 650 doctors from all over Tanzania. And what we do is basically we are starting to get now early referrals from that group, and I think many of you are part of that group. So hopefully we are managing time now much better than what we were doing 1 year ago. And in this year, all of our cases where acute coronary syndrome are coming within 120 minutes who are in local Dar es Salaam. But those who are up country are also getting the primary medical care with acute coronary syndrome. So I'll put a case forward. This is Mr. Ellis, a 66-year-old male who was hypertensive and diabetic on medication and was referred from Arusha 9 hours after the onset of acute chest pain. So what is SCS basically? So remember the case, it was a 66-year-old male, had hypertension and diabetic, had a chest pain, went to a medical center in Arusha and then referred to JKCR. So we'll see how the coordination took place just by a WhatsApp group. So how social media has helped us to improve STEMI care in the country. So first of all, it's the first time in the history now, the guidelines have now changed, where there was always a gray zone between non-ST elevation myocardial infarction and ST elevation myocardial infarction. However, now what they have said that non-ST elevation myocardial infarction should be treated as same as ST elevation myocardial infarction, because we delay a lot of non-ST elevation myocardial infarction patients who become more worse later on and get more morbidity compared to even the STEMI patients. So they have changed the mindset in treating these patients. So it has encompassed the best spectrum of conditions, including patients present with recent changes on ECG, but also encompasses the clinical presentation. Whether you have a troponin elevated, you don't have a troponin elevated, if you have a suspicion and a high suspicion of index on ECG, this patient should be treated immediately for acute coronary syndrome. Now, how does the chain of command goes in acute coronary syndrome? And it starts from the first medical contact, and this is you guys, the emergency physicians. This is where you play a big part to save these patients, where we say time is muscle. And I think the way emergency medicine has evolved, when I was with my colleague, Dr. Ismail, we were the first batch of emergency cardiology, emergency physicians in 2013, and now we've got so many emergency physicians with so many emergency departments in the country. I think we are reaching where we want to reach. So it's the first medical contact, and then how you make the STEMI diagnosis. The primary PCI or a primary strategy to do a PCI, which is percutaneous intervention, or to give a fibrinolytic or a thrombolytic, where if you don't have a PCI capable center. But this all should be done within 90 minutes. Can we achieve that? Even in European countries, some places they don't achieve it. So what they do is they use thrombolysis. In our country, thrombolysis which are available most common is streptokinase, and recently tenecteplase has hit the market, but the cost is the hindrance of tenecteplase. So this is just an overview of what happens, and if you see that this is our heart, and this is our right coronary artery. This is what we see in 2D, and we'll see on the case as well. And this is our left anterior descending artery which comes out. So this is a normal caliber of the artery. This is the abnormal flow, and we call it an end-STEMI or an unstable angina, where there is a partial occlusion but the flow is still there. And these are the patient who goes for stress test, or they go for CT coronary angio, and they found out that they have a lesion which is obstructing but not causing complete flow. And this is what STEMI happens when there is a flow, blood flow. And that's why the guideline doesn't give us license to do thrombolysis here, because the plaque has not developed yet. There is no thrombus here. And that's why in end STEMI we don't use thrombolysis. We use only thrombolysis in STEMI patients because we have a form clot which we want to get relieved so that the flow gets back. So the spectrum starts from here. It starts from the asymptomatic patients where you have a normal ECG. Then it goes to a patient who has a chest pain, and you start getting an ST depression where there is no complete occlusion, and this is called the end STEMI pattern. And then it evolves into become a STEMI. And then it goes into malignant arrhythmias, and you can have cardiac arrest. So it goes very quickly from normal to ST segment depression to ST elevation and malignant arrhythmias. So back to the case now. So this patient basically had a sudden chest pain and started in the morning, and then he was conscious, his Glasgow was okay, vitals, these vitals were from upcountry, and the troponin at first hour was 412, which is obviously raised. This was 1.5 hours from the first medical contact. The patient was loaded, and this is an area, and I was very impressed from this clinic that loaded the patient and sent it to KCMC. So the first primary care treatment the patient got was exactly as guidelines, and we were happy that this patient, the doctor who was there, did exactly what was in the guideline. He recognized the ECG pattern of ST elevation in this patient, where you see there's an inferior ST elevations. He administered the primary care, which is a loading dose of aspirin, clopidogrel, atorvastatin. He transferred immediately the patient to the next facility where he could get a primary care, where they did tenecteplase. They had availability of tenecteplase, and this was done at KCMC. So the patient was sorted at KCMC, and then this case was shared in the group, and then the patient was transferred to Jakaya Kikwete after nine hours. So whenever you see an ECG, I know ECG, even now I get issues with ECG, so ECG is not easy to read, but sometimes there are patterns which mimics an ST elevation myocardial infarction. So what happens is that STEMI has been used even in a mimics of ECG, and I'll go through this chart. It's just mixed chart, but it's just crowded. But look at this. This is a normal STEMI where you have typical ST elevation and you have J point elevation. You have something called posterior STEMI, and this is where we miss the patients. Where you have an ST depression in V1 to V3, we take it as an N-STEMI, but here you need to do a posterior ECG where we reverse our leads from anterior to posterior, and you see an ST elevation. And then you have something called an LCX occlusion, or right ventricular myocardial infarction. This is again a very tricky part to diagnose, and where you have to do, when you do a posterior ST, you get an ST elevation curving like this. So these are tips and tricks when you do an ECG. When you're suspecting a patient with myocardial infarction, typical angina, typical SCS, if you do an ECG and if you have an availability of ECG, do all the leads for your practice. Do this 12 channel and then reverse the leads, put the 3 chest leads back on your posterior and get a posterior ECG as well. Now in some patients we have multi-vessel muscular disease. You might not get a typical ST elevation, but you might be a suspicion of index that there is an ongoing ischemia here. Then you have a left bundle branch pathology. So in a left bundle branch, it's very difficult to diagnose a STEMI patient. But if your suspicion is high that this patient has a typical chest pain, escalate the team to treat the patient. And the last thing is right bundle branch block. This is one of the very rare entity. When you get a STEMI in a right bundle branch block, is the most difficult to diagnose. And recently we had one patient who came with typical chest pain, but ECG right bundle branch block. It was led to diagnose, the chest pain increased, the patient went into cardiac arrest, CPR was done, taken to the cath lab, and we found that there was a lesion, revived back, opened the lesion, and patient was in CCU for a long time. So, back to the ECG of the patient. Now, if you see in this ECG, this patient now arrived at JKCI after 9 hours, and what you see is you see a tall tented T wave in the anterior leads, and a Q wave developed in the inferior leads. Now when a Q wave develops, it means that there is already an ischemic process. Now sometimes Q wave also develops when there is a partial ischemia, and this recovers after some time because this patient was already given a thrombolytic. And if you see this chart, it's a very obvious. So if you see, this is the treatment border. So ST elevation is 0 to 12 hours. Now the guidelines are incorporating that you can now go to the cath lab even after 48 hours, and maximum is 72 hours. There is no benefit in guidelines that after 72 hours reperfusion has benefit to the patient. So unnecessary stents to put in a patient are not done. So what we do is we give maximum 72 hours. After 72 hours, no chest pain, we leave the patient. We don't take them to cath lab. So this is a cutoff, 12 hours, but now it's gone to 72 hours. But if you see, even after reperfusion, you still get ST curving, you still get a Q waves. But this over time regenerates and recovers back to baseline. So you need to give the patient time. Sometimes patients are being done echo and ECG every month or every 2 weeks, but you won't get benefit. So what the guidelines suggest that it's class 1 indication. Once you have your STEMI case, do your first echo after the day of intervention. The next ECG and echo should be done after 3 months, and a stress test should be performed after 3 months, unless the patient comes with any other symptoms. Don't rush to do echo and ECG every now and then. So you are loading burden to the insurance company or the cash paying patient. So the concept of working the final diagnosis, the concept of STEMI versus N-STEMI is determined by ECG coupled with investigations. The guidelines gives just a guide, but the final thing will determine whether there was an occlusive disease or not. Now we have got patients where we call something is new entity is coming, INOCA and MINOCA, where you have myocardial infarction with a non-obstructive coronary artery disease. You have all the symptoms, you have the enzyme release, you go in and you don't find normal coronary arteries. And there is a study going in Poland by Professor Bart where they are doing an invasive physiology on this patient to see the microvascular dysfunction of these patients, especially in diabetics. So again, back to the spectrum, the clinical presentation of the patient. If the patient has sign and suggestive, perform the ECG within 10 minutes of the arrival at EMD. see what is your working diagnosis. Is it a STEMI or an NSTEMI? A normal ECG doesn't rule out acute coronary syndrome. Remember that, my colleagues. Then furthermore investigation, you do a cardiac enzymes, you do an imaging whether you have an LV dysfunction, and then you take the patient from coronary angiogram. When you come to management, there is no harm in giving your patients an early loading dose. The loading dose is aspirin 600, clopidogrel 300, clopidogrel 600, aspirin 300, and then statin of high dose. The only issue when it comes is that nowadays in Europe, they stop giving loading dose at EMD. They give the loading dose once they've done an angiogram. The reason being is that we see a lot of patients with multivessel disease. Now when you load this patient in a STEMI with multivessel disease, the surgeon will say, I can't touch this patient because they have given a clopidogrel. So I need at least 5 days for the clopidogrel to take off. And that's where we can't do emergency bypass in a patient with STEMI. So what we say is sometimes if the emergency physician is in contact with a cardiologist, take the history, especially those who are diabetic, has more triple vessel chance of having a triple vessel disease than compared to a single vessel disease. And then lots of echocardiography, invasive, and I'm sure my colleagues at AMD, they do echo, they do 4-chamber views, they can at least recognize the regional wall motion abnormalities as well. And in the presence of an NSTEMI patient, don't stop after seeing an ECG which is normal. Take your troponin at 0 and 1 hour. And then what you do, if your suspicion of index is low, then you say, okay, fine, this patient is ready to be discharged. If you see that patients have no criteria of this thing, you observe this patient for at least 4 hours in your EMD, get an ECG after 4 hours. If you are fine with that, then you can discharge the patient. If your troponin comes even slightly elevated, don't discharge the patient. Your acute coronary syndrome should be high on your suspicion list. So back to the patient. So the patient was rushed to the cath lab when he came to us. And this is our live angiogram of the patient. This is his left anterior descending artery. And if you see there was a mid lesion in the anterior descending. Now observe clearly the vessels. This is a normal vessel vasculature of a patient in any normal vessel. So this is another view where we see this is left main of the patient, this is your left circumflex artery, and the LAD goes this way. So on the next slide we came, because it was an inferior MI, we knew right coronary artery was the disease. Now this is your right coronary artery, and look at the size of the right coronary artery. It's almost 1.5 times the normal of the left coronary artery. And what has happened in this patient, we call it a post-myocardial infarction coronary ectasia. And this coronary ectasia is basically you can't stent this vessel. This vessel might recover after 3 months, but at this moment what you need to do is you need to just improve the perfusion. Now if you see this is a right coronary artery, it ends up here. There is no flow. And this is after wiring our coronary artery. You can see my wire there. And you can see now there is some flow here. But look at the size of this coronary artery. It's more than the left coronary artery. It means this is typically coronary artesia. So what we do in these patients, we just do a ballooning. So this is my balloon here. And this is not a normal coronary balloon. This is a peripheral balloon because we don't have those size of balloon. That was almost a 6 millimeter vessel. So we have used a peripheral balloon, which we use in a peripheral angioplasty to open up a coronary. And this was the final results after getting the flow back. But if you look at the coronary, it looks like a more of a SFA in a lower limb than compared to a coronary artery. Patient was asymptomatic after 24 hours, completely no chest pain. And the patient was discharged. So what we did, we said that, okay, let's look at what is the availability of thrombolysis at least in the country, and what is the availability of ECG in the country. So we did this study over a WhatsApp group, basically. So we had a form and we did this. And what we found out that most of the emergency department, 96% of our emergency department in the country had an ECG machine. 90% of the people said that we could read ECG. But only 30% had thrombolysis available, and those 30% were all in urban areas and none in rural areas. So if you get a STEMI in a rural area, I don't know what we're going to do. And this is what we are fighting for, to get thrombolysis all across the country, so that at least we can get a first primary care to our patients. And attending doctors, most of them were emergency physicians, and they had the primary dose where they could give aspirin, they could give low molecular weight heparin, but thrombolysis was the one which was missing in these patients. And the referral system. So how do they refer? So some of the patients were referred by letter. So the patient comes after 72 hours, after 1 week. So what we have done now is that the reason for the STEMI group is to refer these patients early by a telephone call or by contacting a consultant cardiologist that we are sending this patient as soon as possible. And if you see here, only very few people would be sending this patient within the first 48 hours. The rest were almost after 48 hours and less than a few days. So first, three things. ECG is an important tool in diagnosis of STEMI, and we say that over 96% of our facilities has an ECG. And then we went more into it and we would ask, and some would say that after 4 o'clock the ECG is locked in the cupboard and it's locked with the key, and the one who is taking the key has to go home. So we can't do ECG at night. So we need to change this practice that the ECG is a very important tool in diagnosing acute coronary syndrome. And this acute coronary syndrome, once you get a morbidity, you get LV dysfunction, the pill burden, the financial cost on the patient and the family is very high in long term. We don't have facilities having cardiac catheterization. Yes, we have only 4 cath labs in Dar es Salaam. We've got 1 in Dodoma. There are 2 coming more in Dar es Salaam. I think SCMC is building 1. So we have no access to the cath labs, but yes, we can have access to thrombolysis. And here comes that you guys at your emergency department needs to advocate to have thrombolysis at your par to treat this patient. So I hope from here, when you go back to your emergency department, you will advocate of having at least 2 vials of thrombolysis for these patients. Once you start using them, once you start seeing your patients improving, I'm sure you're going to get more thrombolysis for your patients, and then refer these patients to us for primary further care, facilitated PCI. And with that, I thank again SQL and Dr. Peter Mabula for inviting me to this conference, engaging with you guys, and I invite you guys to our next conference, which is happening in February in Zanzibar. So this is our conference, and I'll play a bit. So it's in a local language, so pardon me. I hope I can get the volume up. But we are going to have a conference on emergency advances in cardiovascular care in Africa, and we have got over more than 40 international speakers coming in. It will be taking place at Golden Tulip Zanzibar, and we'll have a pre-conference course 1 day before on the 8th of February at Werde Hotel, which will include acute cardiovascular emergencies and how to tackle acute cardiac emergencies. The Prime Minister of Tanzania will open the conference, and the President of Zanzibar will close the conference. The pre-conference course is 150,000 shillings, and you can register. You can register through the website of JKCI, where there is a pre-conference and the conference registration. And I welcome you all to our conference in Zanzibar. Thank you very much again, once again, and hope to have thrombolysis in every EMD in Tanzania. Thank you very much.
Thank you so much, Dr. Kuzema. I know I promised everybody would probably have comments, question after they're done, but we are 8 minutes behind breakfast, and we should never skip breakfast. So we should just add out for the refreshers till 11, and then we're going to come back. I'll take probably 2 or 3 questions before we start with the sessions that are after breakfast. So let's please keep time and all be here by 11. If it's 1 person or 2, I'll get Steve Dunlop to go. So I hope we all can be